and need of the persons and need of the hour, we can say. You all know, you are all invited guests here. You know the purpose of the meeting today. They have coined a very good word, restore. The speakers will explain you what to restore. Now, in media, in persons, in groups, even individually when we are alone, particularly I am seeing all the persons who are above 60 here mostly, youngsters also are facing the same problems which the 70 group is facing nowadays. Earlier we used to say younger age diseases are different from old age diseases, but nowadays there is a socialism in spread of the disease. In the same way, why it is happening is a big problem. Now everybody is having a smartphone in his hand and there is a sea of information before you. Particularly WhatsApp universities are more extensive and they give you an information. It is either disinformation or misinformation mostly. So the need for technical, scientific attitude which sprouts from the correct advice is the need of the hour. That's why Dr. Mohan Reddy in his Nova ENT clinic has taken up this program of meeting all of us, and particularly you see there are less number of patients and more number of doctors in this group. This is mainly to sensitize the doctors, because we ourselves do not know what to tell to our patients and what not to tell to our patients. If you are a homeopathic doctor, you will give a certain advice. If you are an Ayurvedic doctor, you will give another advice. And when ultimately he comes to an allopathic doctor, he will give totally different advice. The patient or a person is totally confused. Added to this, there are a lot of rhetoric speeches going on in the media, particularly condemning the allopathic system of treatment, more so the commercial aspect of the allopathic treatment. We know, at least in our Telugu states, so many persons have become overnight stars in the media. They are all spreading such a, what I told, misinformation, and they are started now talking the scientific basis of that one, where really which is not scientific. They take up certain investigations, they take up few points which suits their argument and are spreading like anything, as if they are the masters or the inventors or pioneers of that system. Particularly, nutrition is the thing. Earlier we used to think there are two things in the world which will attract everybody. One is a bald person like me, he wants hair. For that crores of rupees are being spent. Second is cosmetics. Every girl wants to look pretty. That is the second most this one. Now surpassing all this, the health one and the nutrition part has become fashion of the day. So here we require doctors like Dr. Murthy, who is a family medicine certified person from the American board. We are all eagerly waiting for that one. Now I call on to the stage Dr. Murthy Garu. Please, sir. Thank you. This one. And second, I call Dr. Mohan Reddy, the host. Actually, I should have called him. I will call. Please come onto the stage, because we have to invite them onto the stage. That's why I missed you first. You please come onto the stage. Now we have Dr. Dwarakanath Reddy, who has been our president of Telangana State IMA. I request Dr. Dwarkanath Reddy sir, please come over to the dais. And here we have another stalwart leader who is from our Hyderabad North IMA branch, and now he is in the national leader, Dr. Suresh, as Vice President of the National Body of Indian Medical Association. I would like to call him onto the stage. Please just, this is not a scientific discussion. We are not going to participate. We are all here to bless the new launching of this idea, sir. Your presence is needed. There are so many associates with Dr. Murthy Garu here that the names of the persons who are here we will introduce a little later. Now I call upon Dr. Mohan Reddy to introduce what is R.E.S.T.O.R.E, and there are two speeches here. They are not really speeches, they can be called lectures, or I don't know, even lectures also. It is what you think inside, they will speak outside, and some direction will be given to you. Thank you. I request all of you to be attentive in what is being delivered from the stage. It is not just a meeting. It is not a get-together. It is a scientific meeting. Thank you.
Good evening, everyone. I am extremely thankful to you all for coming in this evening on a working day, though within a very short notice. All of you, my good dear friends who are all come here, I once again thank you all for coming here and joining in this program. Especially my thanks goes to Dr. Murthy Garu, and who is actually based in USA, and very busy physician. Of late he has become so sought after. He was here for the last, I think, 10 or 15 days last year in a program, in Thana program, Dwaraka. We know he gets so many people, such stalwarts, to our place through his connections to US physicians, through his connections to physicians of Indian origin, Thana and all. Now we are going to, like that he came, and in one dinner with Dwarak and all of us we joined together. And then I came to know about him. And later this idea came to us about starting this when I discussed with him. Later, when my son started asking me about his what he should do and all, metabolic medicine I want to do, then I didn't know about that, what is metabolic medicine. First time I heard it actually. Is there any course or like that? I was surprised, and then I remembered Murthy Garu talking on that day about this subject, anti-aging and all those things. Then I asked Dwarak to give his number and connected like that with him. When he came, we all joined, and we exchanged our ideas about that. I told that in our Hyderabad, in my place, I see lot of people with snoring who come with obesity. So I am not happy with the management of obesity with the snoring part we used to do, but it was not a complete treatment. So when I talked to him, he was so passionate a person with this subject and all. Wholesome, holistic approach for the health. I came to know about him like that, and this is how we joined together. Thank you, Murthy Garu, for that. Thank you, Dr. Suresh, for waiting so long. And we will be starting now. I just want Anil to come and give a little about, tell about biodata about Murthy Garu. And here we formed a team now. As I told, in our place, to manage the obesity patients of the snoring. Snoring we used to come across because patients come to us. So many patients we used to see and send them off just like that. Then we thought of this holistic approach. Then we discussed and we formed. He already was into that, and there is a team now. In our team, we have Murthy Garu as our leader, Then myself as a ENT specialist in this center, because we are connected with the ENT snoring and obesity with the comorbidities also. So then he put that it is a wholesome approach for the health, means it is involves a lot of things, diet, our lifestyle, exercise and all those things. So we have made other members like Supraja is here now. She is a nutritionist. She is on. She is from Bombay, I think. I think Anil will tell about them. He knows more about those people. And Dr. Sirisha is there. She was in USA based, and she also is there. And another one is from Bangalore, behavioral Arshita, behavioral modification specialist. She also is there. And Akshay is there, a caterer nearby. He runs a college in Begumpet. So we are going to take him into, he is going to help us. To, so all these program also, I will ask Dr. Murthy Garu to tell, he will tell about as he goes on. So we formed this and we started the pilot project about long back, few months back. Yeah. And for the pilot project, we required a person in the center, in the place, in my place, who can take initial counseling, initial registration and taking the history and all those things. We cannot go into those things, no, initial these things and detailed history and all those things. It's a big subject. And when we go into that, you will all know. So for that, Radhika, Dr. Radhika was with me. She is a ENT specialist along with me. He is joined in my place, working with me. And Radhika, I came to know about her interest. Immediately I put this to her, and you are going to be there, the person, key person in the project and our center to restore health for these patients. So we are all joined now. So with this, I thank you all once again, and I request Anil to come and briefly tell about Sir, and then Supraja, Sirisha, 2 minutes. Okay, please come. Anil, come.
Good evening to one and all. Warm welcome, first of all. We have Dr. Murthy here. His full name is Dr. Radha Ramana Murthy Gokula. He's been in the US, practicing in the US. He has a facility in the US, and he's the director of the facility there. And he's also chairman and managing director of Global Teleclinics, GTC, it's in short form, with whom Nova ENT has tied up. He is American board certified in family, geriatrics, lifestyle and anti-aging, and he's not putting a full stop. It's always come out to him. He keeps learning, he keeps getting more and more certified, and with the intention of helping people. Such a noble person, let me tell you. I know him since 13 years, and there's so many people benefited out of his knowledge. I should give a warm welcome to him. Thank you. And as part of our core team, we have Supraja madam there, and she's a nutritionist. She plays a very core part and has such a hand holding to all the participants as far as their diet and nutrition is concerned, and she takes care of all their queries that are related to the food that need. Her concept is food as medicine. So that's how she is in our team, and we thank her for being part of our team. A warm welcome, madam. Yes. Yes. Yeah, she has completely planned it for you all. And we have Dr. Sirisha Potluri. She is also American board certified lifestyle specialist, and she is the project leader, and she would be handling the sessions for the entire program. It's like a sessions program that we'll introduce you to you later, but she's also part of our program. She's based out of America, and presently she's not available with us today, but she is also a core team member. So this is our short team, and I should thank Dr. Radhika. She's been very, very instrumental in coordinating. The bonding that is happening a lot here between the patients and the team members are because of Dr. Radhika. So thank you all. A warm welcome once again.
Now, without wasting much time, I think Dwarak is here. I think Dwarak also please come a few words about. about our idea and concept. How important and all these things we can.
Good evening, everybody. The only thing I can tell today this is happening definitely is because of me, no doubt. Is the I made the bonding between these two because I know him as Ramanamurthy because everybody knows him as a Gokula Murthy. So it so happened that I know him well because as I'm involved with several organizations, you all know. So one is the TAPI. So we were doing several things, and also he does come regularly to Kana. The Kana ashram is there, so he's one of the important persons out there. So that way I was knowing him. Then at that time it so happened that this sort of a thing was being discussed by Mohan, and that's how they came together and do. Now the things are changing, as we all see that the change of trend in every aspect of every field, and similarly in the now because he started as something else, and now he is doing something else which is of very pertinent to the present situation. So that's how Murthy is in this angle. He is doing good work, and I'm sure that the way that he is doing all that now is going to be useful to the society at large because of the present system of things that are happening. Because again, we are all going back again. We are going back to the 200 years back. What it used to be, now the things are coming back because of all that we are now thinking in terms of so-called modernity, that is giving so many diseases to us, and we are going back and then to naturalized way how to take care of the things of all that is happening. So this is how the things are now in that way. I congratulate Ramanamurthy for taking up this sort of a particular subject and going ahead with that in a all now sort of a with all the with good results, what I mean to say. So good Ravana, I think keep doing the good things in this regard. And also he is another academic person because you all know, because Mohan is one, he doesn't compromise on certain things because he is not he is not at all a commercialized person. That is one thing, because in the present situation everything is commercialized, but he is a person of that not of that nature. He wants only certain things to happen as per the needs. Again, I think the combination is excellent. So I'm sure you people will do a better in this sort of situation. Thank you very much.
So, as Dwarak told, everything is commercialized. I can say that definitely I'm also part of that commercial world. I cannot be 100% sure that in this world anybody can be purely ethical. So, but I believe that we have to go professionally, and commerce should come to us. Finances should follow it. That's how. And Murthy Garu is also such a passionate person. So we join together as such. And most important is after seeing our people among our own doctors also. So many of our friends in our own families, we see so many of us. I used to feel so badly seeing these snoring patients when they come. They come with invariably obesity, and invariably all the obesity people will have snoring and comorbidities also. The percent may vary, percent a little bit, but invariably they are getting associated with these two things are going associated. So in this pilot project, actually, we ourselves joined. Myself, my son, my wife, and Dr. Murthy Garu and all of us, to work like that, how it goes, how, because the protocols we have to develop like that, how we should develop, and all those things we did. And Jayashree, my wife, also is one of the leader in this group because we have started on Murthy Garu. She is taking lead. She was here up to 6 o'clock and went to take care of the, we are all here, a pet dog there, and she came back again. Yeah, that one, yeah. So now, without wasting much time, I will. A few words from our Dr. Suresh, who is patiently here, and he is one of our leader. We all know that lot of subject and some knowledge about life and medicine and our everything about our health care and health aspects and social our health issues related. Please, Suresh, about his ideas. When I talked to him, he was so interested about this subject. I think he came especially to exchange, share our ideas, and all of you should participate in the deliberation.
Good evening, everybody. I actually wanted to listen, and I had no idea that I will be speaking for a couple of minutes. But my interest in this thing was, I was just telling Dr. Murthy, in Ohio State in 2010, when I was in States with my elder brother. He's a pulmonologist with the critical care medicine fellowship. He was doing his, but he was doing fellowship in sleep medicine, and that was the first time I heard of this word sleep medicine in 2010. That's about 15 years back.
Nice sound good.
And he had a very decent book about it, and I didn't have anything else to do there except to read that book. It's very interesting because there are many patients, even in many people, who complain of distress in the middle of the night, not knowing what it is. And they say, I was really struggling, just a sip of water also. So this is there's a big, huge subject, and sleep is a very important part of human life. And disturbances in sleep is makes major changes. I don't want to go into the technical details. They will tell us about how lack of sleep affects many systems in the body. And I'm thankful to Dr. Mohan Reddy for inviting me, and Dr. Murthy for agreeing to address this mixed group of audience and enlighten us about this subject. Thank you very much.
This way only. Have to sit and talk. I think that's better.
Yes.
So a little about how we started. I already told you all. So this is in our NOVA. When I started in 1996, my NOVA hospital, at the inauguration brochure itself and my letter pad also, I used to have NOVA ENT Hospital Endoscopic Sinus Surgery Center, and then I have incorporated ENT specialty clinics, special clinics like, to cover snoring, allergy, vertigo, speech and hearing, all these aspects in one place, like ENT related special issues, special problem, to focus on those things. But now only I could start this in a comprehensive way. In 1996 itself, or around 2000, I bought an ENG machine to deal with the vertigo patients. I bought a CPAP and sleep lab machine somewhere around, I don't remember, long back, around 2005 or so. I bought a sleep lab machine, myself and our boy who is working in our hospital, along with Sai Kumar. I took Sai Kumar also for a workshop on sleep medicine, sleep and snoring in Bombay. We all three went. Sai Kumar joined with me. So now the way I visualized, the way I wanted to do, I think now we have come to that stage. Now we have started with forming the team like that, a comprehensive approach for the snoring patients who come with as I said, comorbidities, obesity and all. So this is the design which of the flow chart made by my son, the left one, and as per that they have Anil designed these protocols, how the patient will go. When the patient comes to us, the center, how they will go. So starting from the entrance to this is the flow chart Ashish made and shown to Murthy Garu 6 months back. And later on we designed these things. In what all we have done in the pilot project, I am telling about this to begin with. So the patient will come here, counseling, and then all those things, no, he will pass to ENT consult. The first thing what they need is a ENT consultation, because I'm not telling this because I am a ENT man, but the snoring starts in the throat. Snoring is because of obstruction to the airway. The calling obstructive sleep apnea itself shows there is an obstruction where upper airway obstruction, whether it is complete or partial. So the reasons in the upper airway obstructions have to be seen first. Obesity is contributing to the obstruction by narrowing the throat. So it has to start with evaluation of the patient, and the patient also comes to us only first. They come to us only first. And then after evaluating, the comorbidities will be there, obesity will be there, we see. But what to do with that, we used to worry. Now we have come to the solution. That's how we have formed the team, and that's how the patient will go in our center. With a flow chart like that, they will go. The physician will see next, they will assess the lab reports and all those things. Then after that, we decide, both of us, who has to tackle the patient first. Whether it is a surgical correction of the airway, when there is an airway block, we have to open the airway. That is what we have to do. How to open the airway? If the obesity is there, see, it is all, fragmented approach we are having even now in our all the places, pulmonologist treating, cardiologist treating, neurologist treating, and so many other people are tackling these and they are presenting themselves as the sleep medicine specialists and all. But there is no team approach. That is what we have seen. So when we decide who should take first, based on how, what criteria we have to decide, all those things I will come to that next. So snoring, what is snoring and obstructive sleep apnea? The definition is, see, it's one of the sleep related breathing disorders. One of them. All the other sleep disorders, we know that classification is there. I don't want to go into. OSA is sleep related breathing disorder characterized by repetitive episodes of apnea and hypopnea, that is cessation of breathing, complete or partial. Hypopnea is partial. And then upper airway obstruction during sleep due to that. And in spite of the patient struggling, they will be struggling to breathe, but they cannot open the airway. That's what happens. And the definition of apnea, hypopnea, apnea is 10 seconds of cessation, more than 5% of desaturation will be there. And hypopnea is 3 to 4% of desaturation with a partial block, airway block. There are a lot of things, we study in those things. So I want to tell you that it is no more a laughing matter. Definitely everyone knows now, awareness has come. And our loved ones, I think we are lucky in India, but abroad they are giving divorces. They don't consider it as a love song, snoring. So incidence, the snoring is about 30 to 50% of the population above 40 years of age, but everything is not serious, severe obstructive. They won't go into obstructive sleep apnea. Everyone. The 2% of women have got and 4% of the men are double the number, will have the moderate to severe where they require definite intervention. But even milder ones also, now we came to know that there is a syndrome called upper airway resistance syndrome. So partial block, even less than 3 to 5% of desaturation happening, even for them, they will go into a long term, they will go into these kind of consequences, including not only obstructive apnea, they can go into, even without complete obstructive apnea, they can go into metabolic problems, obesity, metabolic problems related comorbidities, all the diseases, they can go into that. So all the snorers, partial block also, there is upper airway obstruction problems, they have to definitely consider this. So what is happening exactly is the airway here that collapses, pharynx level, upper airway. There are 4 levels from nose, level 1, level 2 is a palate and oropharynx, and then level 3 is a tongue, and level 4 is a larynx level. This is upper airway curve. So when there is a narrow, already the narrowed airway because of either anatomical problems in the nose or in the throat because of the obesity, fat deposition, the narrowed airway, when they breathe, they try to struggle and breathe fast, the air goes very rapidly and it will create Bernoulli phenomena, we know. Because of that, it will collapse and pull the tissue concentrically and further aggravates in the long run with the deposition of fluid and inflammation and the deposit of fat and all those things. Such things will happen. That is the mechanism. So the causes, I said, obesity and age above 50, male more common, and irregular sleep habits, all those things will be the complicating compounding factors. Anatomic factors, these are mostly very important for us surgeons, particularly upper airway surgeons like ENT, maxillofacial surgeons. We deal with the surgical correction of the anatomical blocks. And like tonsils, these snorers, originally even though their airway and upper airway anatomically normal, over a period of time, because of the fat deposition, the palate, uvula, base of the tongue, everything becomes, swollen, bulky, and they cause narrowing. These structures also we address, not only that deviated nasal septum kind of things and polyps, very clearly seen polyps in the nasal cavity, sinus diseases and all those things, allergies, we deal with them. So we have to deal with the obstructions like that as surgeons. Later on, to sustain our team leaders like Murthy and physicians, they have to do everything. So who should do first, who should do next, that is what the criteria we have decided after deliberating experience. So this is how the patient looks with the classical snorers and OSA patients with the facial and fat deposition around, and the throat, you see, over my crowded throat with the uvula, big huge tonsils, huge tongue, and the palate also, redundant mucosa, and all those things will be there. So this is the situation, as the parapharyngeal fat and the parotids also, they become like this, and they all constrict. Sometimes we advise even parotidectomies. Cherubism, we know that some people will have those things. To relieve the obstruction, we require surgical procedures like that. Our physician friends should know these things. As a team, we all should know each other, each aspect, so that we can comprehensively manage the patient for the best outcomes. One single ourselves, we cannot get the total result, and total result will not come only with these things. So this is that is why. So why does OSA increase fat in the regions? I told you already. There is a regional distribution of the fat. OSA patients often have excess fat around in the tongue, parapharyngeal space, and the submental area and neck fat. Mechanism is intermittent hypoxia causes inflammation, and this inflammation alters the fat metabolism. I think Dr. Murthy will go more deeper in that. So the neck circumference is very important factor which we take. A neck circumference in male people, if it is more than 17 centimeters, 17 inches, and in female if it is more than 16 inches, a very important factor in considering about the intervention for those patients. And abdominal, at the umbilical level, abdominal circumference also very important. So this is how the fat gets deposited, and obese with OSA and obese patients without OSA, there were studies like this. So when there is no OSA, the fat was not there in the neck circumference. You can see that OSA people will have this kind of a larger deposit of fat in the tongue and the parapharyngeal area, all these areas, parotid area, we see that. Visceral fat also will be markedly increased in OSA patients. Some people, though they are obese, they will not have obstructive airway syndrome, like oxygen desaturations and all will not be that much, though they will be very heavy. We see in our experience also. For them, the fat deposition will be only subcutaneous levels, probably. That is how it is observed. So, what can happen with the snoring? As I told, we already know health ramifications, lot of health ramifications. We know that all those aspects. I think Murthy garu will go into details. The symptoms will be morning headaches and daytime sleepiness, loud snoring. These are the very important symptoms: loud snoring, gasping during the nights, morning headaches, daytime sleepiness. One of our patients whom we have treated, Radhika, will tell, he comes to Hyderabad from Nizamabad. 10 or 15 times he used to stop car and sleep and come back again. Some patients met with we have seen like that. We all know those things. So went to consult, as I told, very loud snoring and stopping breathing by partner, gasping, daytime sleepiness. These are the things. These are the evaluation forms, different kinds of evaluation forms in the literature. But ultimately, after going through the subject thoroughly, I have designed a way which is more appropriate, I thought, for our center. This is my design. I coined my name, Dr. Mohan's OSA assessment form. I think Dr. Radhika will be dealing with that details, how we are doing. So the level of obstructions and diagnosis, all the tests what we go into is clinical and nasal endoscopy we do to locate the cause of obstruction, disease or anatomical structural problems, DNS and all. At what level is the main obstruction? We have to find out. Otherwise, the procedure, surgical procedures, if we don't target to the main obstructive element, whether it is tongue base, whether it is in the nose, whether it is in the uvula, palate, or in the larynx. Sometimes we have seen epiglottis blocking, collapsing and all. So the polysomnography is a gold standard evaluation. I cannot go into all the details now because of short of time. So oxygen saturation level and nasal airflow, degree of respiratory effort, EEG, electrocardiogram, all these things, parameters we take into consideration to assess the risk in such a patient, in a patient whom we have to immediately go intervene like that and alert them. So this is how we classify the apnea hypopnea index classification. It's less than 5 events we call the apnea hypopnea events in a 1 hour sleep. If they are less than 5, it is normal. If it is 5 to 15, it is mild. 5 to 15 times of 10% of 10 seconds of cessation of breathing. They will stop breathing and they suddenly, after stopping, the oxygen falls, carbon dioxide accumulates, and that will drive the brain to arouse the patient. The brain will, we know that carbon dioxide stimulates the carotid receptors, and it will create, in turn awaken the patient, and suddenly he will turn like that, struggle like that, and again start breathing like that, gradually increasing this snoring loudness. We know that if you see a sleeping patient, we know that. So 15 to 30 times if they stop, it is moderate, and more than 30. We have seen patients who had 175 times stopping breathing also, even more number of times also. Snoring events, 1,000 times of this thing. So mild, moderate, severe based on the number of apnea and hypopnea events and saturation levels also. We combine that, when there is a 86% of level or more, not less than 85% of oxygen desaturation. It is mild. If it is more than below 85, that is 80 to 85, moderate, and then if it is below 80, if it is, that will be considered as severe kind of desaturation. So the treatment protocols, there is a thing called CPAP. I think many of you know. It's a continuous positive airway pressure machine. We will provide with a mask and all. The person has to sleep like that. One of my close friend, he is very happy for the last nearly 25 years he is using, but it is not same with every patient. We find complaints in less than 70%, and not even less 70. We have seen 50% of the people only can adjust. That also in the long run, even that number also will become less. So lifestyle modification is very crucial part. That aspect Dr. Mutigaru will deal, and surgical treatments are important. So I said palatal surgeries we do like this: UPPP, palatopharyngoplasty, laser assisted palatoplasty, cochlear assisted tongue base reduction, epiglotopexy, adenoids and tonsils in children. Very, very important in children. Please remember this. If you have your own family members and friends, any child having noisy breathing, immediately we have to attend with sprays, nasal sprays, warm steam inhalations and all those things. And we can also subject them for oxygen saturation levels, how they are going, with the oximeter also we can see. Nowadays I think in the cell phones also the apps have come. We have to see if there is a grade 1, grade 2 adenoids and tonsils. We don't advise surgery, but definitely grade 2 to 3 and 4, 3 and 4 definite surgery. 2 we have to follow, observe those people, children. So this is how the throat looks, the Storer's throat is normal, and see this, how narrow it is. Lateral pharyngeal walls also got collapsed. This is how the epiglottis, this is epiglottis there. See how bulky it has become. Entire tissue, pharyngeal mucosa, bulky it has become. And we do the DICE, that is drug-induced sleep endoscopy. We give propofol in a low dose, 1 milligram per kg body weight, like that we give induce and make them sleep. While sleeping, we introduce the endoscope and evaluate the level of obstruction. This is how we do this evaluation with the sleep endoscopy. I think you can see that. See, that is the uvula, this is the epiglottis. See the epiglottis, how it is collapsing. This thing we cannot see without doing endoscopy. Now, this sleep endoscopy is the gold standard to identify the place where. See, that is how it is obstructing the airway. It is collapsing. These people cannot be benefited by just only nasal surgery. We have to do palate, also epiglotopexy for them. This is how we see how the saturation falls and all those things. We see them. So these are the surgical procedures we do. These are there are a lot of modifications and evolution in the surgical procedure. Depends again the patient's palate, type of palate, and type of pharynx, lateral pharyngeal wall collapse, or the anteroposterior collapse. Depending on those things. This is a classical one earlier, the first one, UP3. Entire uvula and soft palate was resected and sutured like that. Nowadays we don't do that like that. We have modified them, refined them. With the barbed wires also we are strengthening the palate, soft palate, and this is how the after surgery looks. Earlier we have seen the uvula, palate, how bulky it was after removing the tonsils, and the uvula also. I have developed, I think Radhika was appreciating me. I have not seen before this uvula reconstruction, because it will be totally removed in all the procedures by the people except for the palatal strengthening. When we do uvulopalatoplasty, they remove the uvula. So when we remove the uvula, there will be dryness in the throat and there will be foreign body sensation. So I started reconstructing it, and this is how it looks with a small uvula and nicely. There are so many other modifications, tongue base with the radio frequency, we reduce the mass like that, and so many things. Details I don't want to go. This is adenoids, with the debrider. I started first in Hyderadad to use the debrider endoscope. See, that is the adenoid, how it is blocking the coina, posterior nasal aperture. It is totally blocking there. I use the debrider and endoscope. I remove the adenoids. Later, when we see, it will be nicely opened up. See, that is how I use the debrider, and just to give an idea for you, after completing that, it will be put. At the same time, I do the grommet for the ear. And this is the uvula. See, that is how I resect the uvula partially and create some flaps from the side and then reconstruct the uvula. That's how I am doing, using the radio frequency needle. That's how the uvula, see, that is the uvula. I am holding the uvula and reconstructing that later. So, to summarize, it is a vicious cycle of obesity and OSA. So obesity and OSA reinforce each other, and they go into a self-perpetuating cycle. So OSA fatigue like that, by hormones and all those things, Murthy Garu will go. And OSA is not just obesity. It is not just obesity, what I mean to say. Weight loss alone doesn't cure OSA. These interventions are very important. That's what I want to stress for the people, physicians, especially, we need a comprehensive combined team approach, including our nutrition specialists and also behavioral specialists, behavioral modification specialists, to motivate constantly. We know that we ourselves cannot follow the things for a long term unless somebody will be constantly friendly, motivating words we need, and that is very important. I always say that even Tendulkar needs a coach constantly. They sometimes say, no, you go now, go and bat, run. They will say like that also. So we need those team people all. So weight loss alone doesn't cure OSA, but weight loss even to the extent of 5 to 10% can cause clinically significant increase. What I mean, weight increase. Even 5 to 10% cause significant recurrence of OSA after surgery. That means weight loss is important. But the opposite is also true. Surgical restoration of upper airway plays a big role in maintaining the patency of the airway, and simultaneously when the team deals with the patient, the compliance and all will be very good, and sustaining results will be there, and better long-term airway patency, and CPAP compliance also will be definitely. CPAP with the nose, obstructed nose and polyps, definitely those are obvious things. You cannot, even the machine which pumps also, the air won't go in a blocked airway with the big tonsils and all. So that is very important, and metabolic to relieve of that. So to conclude, OSA is a complex disorder. All the treatments are only moderately successful if they are applied alone. If they are applied alone, they are only moderately successful, including lifestyle medicine or surgeries also. So we have to combine. So once again, to conclude with these words, thank you.
So this is a tough act to follow, right after Dr. Mohan Reddy Garu. Thank you very much. Please give him a big round of applause for actually bringing this whole act together. Without his vision, I don't think I could have been here sitting down. And Jayasri Garu also, who has redesigned this. And I want to thank my team, and thank you all for 9 o'clock. You're still here sitting. And I promise you I'll finish this very quickly. I just want to see a raise of hands. How many of you think OSA reversal is possible medically? Surgically, he'll take care of. I don't need to worry about surgeon. I'm not a surgeon. But medically, he deals with the surgery. It's his job. But medically, And there is so much published evidence and so many clinical trials done that you can do it. So I was a family physician, geriatrics and hospice palliative medicine. I was a program director. I left the University of Toledo in 2016, and I wanted to create what is called healthcare, not sick care. Because you all know, right, dealing with geriatrics, 65 years and above, hospice is you're dealing with dying patients. So I've seen disability, frailty, but I wanted to do healthcare, and I wanted to say patient is the boss, doctor is the coach. And you might be wondering why behavioral person is important in this whole game. Because everybody knows knowledge now. You can use AI and get all the information. But how do you change behavior? So there are 5 stages for change called pre-contemplation, contemplation, action, maintenance, and relapse. So in the pre-contemplation and contemplation, a human being needs what is called motivational interviewing. And then in the maintenance phase, life is all good. But it's when relapse happens, because you all say diets work for a while, but then they go back to their habits. The reason is because habit formation is what we are trying to, and I'm going to kind of surprise you that our Indians have pioneered this 3,000 years ago, and here we are looking at lifestyle medicine from America trying to tell us how to do care. I'm both certified in longevity medicine, anti-aging, but I blended both lifestyle because you have 6 pillars in lifestyle medicine: exercise, nutrition, stress management, sleep, addictions, and social relationships. There are 9 hallmarks for aging. But what I wanted to kind of emphasize is that what happened? Is that okay? Oh, it's gone? What happened? So basically and then I kind of, so let's take this off. Is that okay if oh. Right? So, thank you. So if you can see, as you all know, for the non-doctors here in this room, systematic and meta-analysis mean that they look at all the research that is published. They all they all put together the apples, the peaches, or the grapes, all they divide it, and they kind of really put a lot of science to find out what exactly is the answer, and they actually help you. It was done in weight loss and lifestyle interventions can actually change. You can see how many studies, 1,420 participants, the apnea-hypopnea index, the oxygen saturation, daytime sleepiness, they all have improved significantly. And the way we do it is through lifestyle medicine. But what are the drivers of chronic disease? So if you have inflammation, he has kind of mentioned it, insulin resistance. What's inflammation? It's not what you talk about when you get an injury. That's an acute inflammation. But here I'm talking about chronic inflammation. Every day, now you're eating something, you're drinking something, your body actually is inflamed. And from there, healing happens. But if it is persistent and it gets into low grade, then it's called inflammaging as you age. And that's the cause. Because once you are inflamed, a lot of inflammatory markers come out, and then they cause insulin resistance. They cause heart disease. Because people think blood pressure is because of high elevation of blood pressure, right? So 120 and 80 above. But there are 3 mechanisms that actually happen in the blood vessel, which is inflammation, oxidative stress, and autoimmune dysfunction. So that's the reason I put together the 8 drivers of chronic disease. So chronic low-grade systemic causes airway inflammation and drives OSA progression. Insulin resistance. I don't need to do a lot of tests, but if for academic reasons, there is what is called HOMA IR that you can do. In the interest of the time, I'll cut down, but you can just check. If you have this belly here, then you have insulin resistance. And when you have insulin resistance, where do you get the insulin resistance? Can anybody say, why do you get diabetes? What's the cause? Why do you get diabetes or pre-diabetes? Anyone? What do you normally hear your doctors telling you? Stop eating a lot of rice, right? Which is carbs. Diabetes is because of fat. Each gram of fat gives 9 kilocalories. Carbs and protein give 4 kilocalories. When you add more calories to your diet, so what happens to the rest of the calories after you spend what you need? It turns to fat. And where does it go? Here, here, in the armpits, in the belly. So the problem is in the thighs. So this is the visceral fat. So it's the visceral fat that's more important in obstructive sleep apnea that causes the insulin resistance. And when you have more fat, then a lot of inflammation happens. Where do the toxins go and stay? In the fat. So and then they cascade more inflammation and then more swelling. So it's very important that you go to the root cause. That's what lifestyle medicine, longevity or functional medicine is. Toxins. A lot of people think heart disease is because you have a high cholesterol and you get heart disease. Just living in Delhi, because you inhale the 2.5 parts per million particles, you actually lose 8 years of your life. So pollution, there's toxins. And toxins, you can see VOCs and environmental exposure exacerbates airway inflammation. I just saw a patient today who has a lot of inflammation in his lungs, and the point is you have to reduce the underlying inflammation. So in India, I've never seen, but I have used a medication called naltrexone. So when naltrexone is used for 25-50 milligrams, it's for alcohol and drugs, addictions. But I use in America below 6 milligrams. We call that low dose naltrexone. I don't have that in India, but I still try to monkey around with 25, cutting it to quarters and all. But these are some of the things that in a holistic approach we use. Below 6 milligrams, it is a very strong anti-inflammatory agent and immunomodulatory. Because once you have inflammation, autoimmune sticks in. I'm sure you all have heard, once you have arthritis, then, you have thyroid disease, like hypertension, cholesterol, heart disease, diabetes, stroke. These are all the cascade of events, but the underlying root cause is the inflammation, autoimmune dysfunction, and the oxidative stress. And then hormones. When you have a lot of inflammation, your thyroid gets changed, reproductive and metabolic hormones. I just saw a patient who is right in this room, but his hormones were checked. He can't sleep. So in a holistic approach, what we do is we give him magnesium glycinate, which is a wonderful muscle relaxant, and you sleep well. And then his progesterone was less than 0.3. A man also needs progesterone. There are progesterone receptors in the airway. There are estrogen receptors in the airway. Even a man needs all these things, but we think it's only testosterone. His testosterone was normal. But I put him on progesterone because progesterone helps to sleep. It could be that that's his main cause, despite all the surgical issues. I'm not saying, but I'm guessing. I'm just saying I measured, and in a holistic approach, this is what we do. How many of you people know gut problems actually cause sleep apnea? Because it leaks. I check gut microbiome, and there is significant research that if you fix the firmicutes bacteroides ratio, which we can check and reverse it, and reduce the systemic inflammation, which Dr. Reddy already said that is one of the key causes. But how do I reduce? I'm an Indian, right? I want cheap stuff. I don't want to give supplements, trying to give probiotics, prebiotics, all these medications. Eat a lot of fiber. Where do you get fiber? Plants and vegetables. So stem cell dysfunction, when you have a lot of oxidative stress, and the same patient I'm talking about, because that Dr. Reddy has mentioned, his ACTH was like 23 when the upper limit was 12 because his prolactin was elevated. When somebody is stressed, these two hormones go up. So that impairs the stem cell dysfunction, and then you can't repair yourself. Mitochondrial dysfunction, when you have repeated hypoxia, you have fatigue. That's caused, then they don't sleep, early morning they have fatigue. So when genetics are affected, then because we call that DNA methylation, which is the MTHFR gene, and that causes changes in metabolism, airway genes also as well, and you can reverse this with therapy. When you age, your genes reduce in size. We call that telomere shortening. Can you answer one thing that is simple and our sages have done that helps prolonging of the telomere or the genes? There is no pill here. You don't have to spend any money. It's called meditation. When you meditate daily, your telomeres prolong. So our Indians have figured this out thousands of years ago, and I call that Ashtanga Yoga. You all heard of it, right? Patanjali Yoga Sutras, Yama, Niyama, Asana, Pranayama, Pratyahara. These are all about bringing health to your life. Dharana, Dhyana, Samadhi are about happiness. So you need all these 8 things. 3000 years ago, Patanjali said how to lead your life. So I'm taking those to create habits to cause health transformation, because those were designed for cell transformation. So now I'll show you real data, how inflammation affects. It drives the disease progression, causes cardiovascular complication, and when you actually do CPAP and lifestyle, reduce inflammation and improve outcomes. So sleep. If you don't sleep by 10 p.m., it's very difficult for you. 10 p.m. to 2 a.m. is when your body regenerates. It rejuvenates and restores itself. If you can't sleep by 10, you're losing because it doesn't detoxify. What happens if your toilet is blocked? It stinks. Same way your body, if you don't sleep by 10, it causes inflammation and causes the problems, which I didn't know as a family doctor. I went to lifestyle medicine course, and that's how insulin resistance, because of lack of sleep fragmentation, because there is sleep fragmentation, it causes insulin resistance issues even in non-diabetic patient. Today one of the patients said, I don't have diabetes. I said, that's fine, but you have insulin resistance because insulin was high. So in holistic approach, we check the insulin. We don't wait for a hemoglobin A1C or fasting diabetes. Once you have elevated insulin, that's a disaster. And insulin resistance diabetes actually cause OSA risk to go up. Hormone, I told you, progesterone and estrogen stabilize the airways, explain the gender differences. So if you don't have progesterone, you could be causing, sorry about that. So testosterone also affects across the lifespan, and thyroid. Some people will have elevated thyroid antibodies but have normal thyroid function. In a holistic approach, I give them 3 things to do. I fix their gut, I take them off the gluten, and I put them on naltrexone, and that changes the game. I've reversed my thyroid antibodies, but my CRP went down. So the point is, you have to look at hormones as well. And the gut-brain sleep axis, it's huge now. Have you heard of this, ENT doctors, the gut-brain sleep axis? It's been really talked about a lot now. Gut-brain sleep axis, gut-heart axis. So every disease, your gut has a, so when you see in obstructive sleep apnea, the Firmicutes bacteria ratio is increased, and there is neuroinflammation and metabolic dysfunction. So when we do a lot of fiber, sleep hygiene, probiotics and prebiotics. So in my patients, I ask them to stop looking at the phone at 8 o'clock. 8 to 10, they have a bath, do yoga, pranayama, they actually walk if they want to. And one best way and easiest way to reduce your insulin resistance is to walk after each meal. You can check, you can put your continuous glucose monitor or check your glucose before and go for a walk after you eat. Like you ate now, check your sugar, go for a 30-minute walk, come back and check it. I guarantee you it will drop. It doesn't matter which kind of exercise, but walking, but if you do even more, you actually, these are simple tricks that we use to reduce sleep insulin resistance. Mitochondria is very helpful because of the hypoxia. The mitochondria are damaged and they have cognitive impairment, and we use antioxidants. What is the best way? As far as I am concerned, you should eat a rainbow color of foods. If you like dondakai, you can't eat dondakai every day. You got to eat beetroot, carrot, apple, pomegranate, berries, if you get it here, but colorful. So what did Ayurveda teach in the past? Based on the seasons, they created what is called Vata, Pitta, Kapha, based on that each season, and they talked about eating the seasonal and growing locally vegetables, because that influences the gut microbiome. Our Indians, then they did what is called fasting. Stem cells, when you fast, for cancer patients, it's the best thing to do, because it creates autophagy and stimulates stem cells and kind of helps in their recovery. But we have figured that out. So I tell my patients, based on what I understood, these are the 6 poisons. I don't know how many people will like it, but I make sure that they follow. I forgot the paper, but I'll be happy to leave it here, send it here, and you can give it to everybody or email it. My patients, everybody must stop processed foods. You eat the produce, not the product. No processed foods. They all have chemicals, and when you eat, body doesn't know anything but to create inflammation. Potato is good, but potato chips are bad unless you air fry them. So processed are a disaster. Sugar is very inflammatory. I'm an anti-aging and regenerative medicine. If you have a tennis elbow, I use dextrose water with lidocaine and I inject here, and tennis elbow is gone. I heal ligaments by it's called prolotherapy. If that doesn't work, then I add peptides to it, then I do. But the point is, sugar is inflammatory. And how many times we drink tea in India? Quite a lot of times, right? 1 by 2 chai, lot of times. And then we eat maida, Usmania biscuits. So refined flour is a disaster. Please, naans, disaster. You don't have to do anything. Just eat these things, you'll create inflammation. And you'll change the insulin resistance. Processed food, sugar, refined flours, dairy. Why dairy? It was nice and pure in the past, but now everything's hormone. In US, every cow has as a pellet. They have hormone pellets. And for the udders, they all give antibiotics to prevent infection. So all the milk gets tested for hormones and antibiotics. But if you just think, why is milk there in the first place? Nature gave. It's to give all the growth factors, like insulin growth factor, which is like you feed cancer if you give insulin growth factor. Sugar creates insulin growth factor. That's why sugar is a disaster in cancer patients. So the point I'm trying to make is, milk was designed for the calf, not for human consumption. But we have made it so that it becomes, and then on top of it they add oil. So processed food, sugar, animal products. Why I don't like animal products is not because I was a vegetarian from my child. No, I was a non-vegetarian strictly 3 times a day. But when I learned at Harvard for a 5-day course, when you eat meat, it causes 3 things. TMAO. TMAO takes cholesterol and puts it in the blood vessel. Heterocyclic amines and activated glycated end products. These 2, they cause cancer. How many of you have heard that we are having a rise in cancer and heart disease? And that's your answer. Because when I was a kid, we used to eat on a Sunday, and it was a joint family. You hardly got 1 or 2 pieces. Now you don't need to. You can get your half chicken. So that's your problem. So meat, animal products, dairy, refined flour, gluten. Wheat was good until we had a famine and a university guy from California did genetic mutation to the wheat. And then that changed the game. Now India, I heard, they're going back to the original seed. But the problem is, try this on your own self. Processed food, sugar, animal products, dairy, refined flour, gluten. you stop all these 6 things and see what happens. But I don't want you to become restrictive. Lifestyle medicine is not restrictive, it's inclusive. So when you stop animal products, eat whole food, plant-based. Indians were given millets, eat millets. You can soak millets for 12 hours and cook it in the next morning, it will taste great. Instead of animal product, eat lots of fruits and vegetables. People think you get diabetes. They have done prospective studies, like looking forward 19 years, giving diabetic patients both type 1 and type 2, lots of fruits and vegetables, and it didn't really do any macro or microvascular complications. Yes, the sugar will go up. I will agree that. Mango will go up. That's based on the glycemic index of the fruit. But the point is, animal products are much more disaster than this for diabetes patients. If you want to reverse your diabetes, 3 things. Give up all the animal products. Give up all the oil. And eat as many fruits and vegetables. I have a lady here who said she followed these few things and lost 4 kilo, even without seeing a doctor. And I have reversed psoriasis completely with just stopping those 6 things and following lifestyle. Smoking and alcohol are a disaster. Epigenetic changes. Lifestyle medicine reduces epigenetic, because in stress reduction, I ask people to meditate. In stress reduction, it doesn't have to be everybody has to become a saint. You need to start doing activities that you don't know or you love, and then it becomes, so biological aging is actually better when you actually reduce the inflammation, take care of the airway function. So we use what is called a whole food plant-based diet, and that's what you're going to eat today. Sleep by 10 p.m. Make sure that you use glass bottles. Plastics are a disaster. And movement is medicine. Do mindfulness and have good social connection. In India, social connection we definitely have better than Americans, but here also, based on your state, based on your caste, if you get together, that's not social connection. Social connection is when you wake up, how you treat the next human being, how you treat the environment, how you treat the animals, how you treat the plants. This is what is your social connection. And UK, actually, when you walk in nature, if I write a prescription, the UK people will actually pay the employer, because just walking in the nature reduces anxiety and stress by 25 to 30%. It's called nature walking. So these are all things that our people have figured out. Weight loss, which one actually causes, you can see here, CPAP only gets to you certain extent, weight loss to certain extent, but intensive lifestyle creates a large portion, and that's what our collaboration is all about. And he can take, and whole food plant-based diet is really the key, and the best way to do it is weight loss plus multimodal approach, wherein you have to have behavioral approach. That's why we have a team. And I want to kind of address that you got to address all these 8 pillars, and that's my job. And these are all the clinical trials. Mimosa trial that was seen in 187 overweight, and they actually reduced for 6 months. They literally reduced sleep apnea, and you can see the outcomes, so they reduced daytime sleepiness, decreased insomnia, increased, and it was p value was less than that. In interest of time, I'll kind of say these are all the interapnea trials, CPAP free by this 62% in 6 months. So you can literally get out of CPAP machine. And sleep ahead study is another research study, average weight loss 7 and 76% reduction in risk reduction. So in our approach, we try to promote the lifestyle modifications by addressing the 6 pillars, but if in case they can't lose, I use definitely weight loss injection, GLP-1, there is new research and data that you can actually do, and this is a sleep ahead study, 10-year follow-up, that they have shown that you can sustain by changing the lifestyle, and this is how we can help patients lose weight in a holistic approach. These are all the data, and the power trial is a good one again, that the clinical outcomes are significant in both cardiovascular and obstructive sleep apnea. But we do labs for all these 8 drivers, and based on that I address and we actually create a chart, then NOVA forms are filled, I review them, we create, so like you all doctors will give prescriptions. In lifestyle medicine we call them SMART goals, specific, measurable, achievable, realistic and timely, and we give them for the 6 pillars fit prescriptions, frequency, interval. We don't just say go and eat less carbs, we'll specify what you must eat, and that's what Supraja does based on, and Sirisha will do, and I review the patient, and then I would like to kind of have, and then follow up with, we do all the things, and probably the way we can transform is from sick care to health care is by doing a holistic approach. Are you speaking? 9:30. Okay, so can you just briefly tell your experience? Thank you all. If you have any questions, I'm here.
Yeah. 4 minutes, Radhika will present our pilot project, a number of cases and all, what our observations. These are preliminary observations and few cases, examples of outcomes.
Backside of the. I'll talk a little while you're eating, and then you can take refills from the table here. Yeah.
You will be talking while they are eating.
Yeah.
Yeah, good evening everyone. This is this presentation about how we evaluate OSA cases, especially the NOVA ENT. Mohan Reddy sir himself, this is how initial primary questionnaire looks like. There are so many questionnaires so far accepted worldwide. One is for sleepiness, one is for assessment, risk assessment, one is for symptoms. So that is all become so so elaborate. So this is very concise form how it looks. Initially we take questionnaires includes, well sir just depending on the severity grading was given. It was like if it is less often it was B, and if it is daily or moderate it is A. If it is very severe and intense, patient definitely needs a treatment, it is A plus. So first criteria is whether patient snore or not. And above age 50, its age itself is a risk factor. Age and male gender both are risk factors. And when this snoring was noticed, if it is in the recent few months, it's less B type, and if it is more than 1 year, it's A. And how often how loud the snoring was. If it is just audible just besides to the person besides, it's a B. If it is disturbing very loud and hearing to the next room, it's A plus. That person definitely needs the treatment. And how often that person snores? Is it every day or once in few times in a week or few times in a month? And the next point is it throughout the whole sleep or sometimes it's going on and off, on and off? If it is throughout the whole sleep, the obstruction is very severe. And any other complaints along with the snoring. Patient, if it is symptomatic, the more patient symptomatic, more is the severity of the disease. Like the symptoms includes difficulty in breathing, patient wakes up with the morning headaches, and patient keep complaining about tiredness, fatigue, daytime sleepiness, and associated other problems like repeated episode of nose blocks, repeated episode of the colds, repeated episodes of the throat pain. These are all very much significant. Simple snoring is not significant. If something is disturbing the patient, that is very significant. Snoring can be simple sound, or it itself is a disease and it can contribute to other diseases. And by the time patient coming to us, they are already having treatment. They develop hypertension early in 40s. They may develop diabetes in their 30s. So we'll take other factors also. What are the comorbidities they also develop, like obesity, hypertension, heart problems, hypothyroidism, PCOS. And snoring, patients have the apneas. Apneas means if apneas per self, patient can't perceive the apneas. That can be told by partner. And if patient feeling that choking or apneas, that obstruction is very severe, then it is categorized to A plus. And if anything helps to reduce the snoring, like some people they comfortable sleeping to the sides, they sleeping in prone position, they sleep with a pillow, with raised pillows, means these are the things helping to relieve the obstruction. Something is relieving the obstruction, it's good. So it's given B. If it is not relieving any obstruction, that is A. Depending on all the symptoms, patient was characterized into very high risk, code red was given, and high risk. Code orange, low risk is the blue, and no risk is the green. Very high risk patient, sleep study and treatment, everything is very essential. And high risk patient also, treatments are essential. Low risk patient, sleep study is optional, and treatment we can try preventive lifestyle and causative factors, we can address them. And in the whole year, these are the statistics, and we enrolled the total, and we developed a clinical examination form also. So initially we take the patient with this questionnaire and clinical examination form, and we'll put them into which category they come. We have enrolled total 44 patients, and in this very high risk category are the 39 patients, and high risk category comes to 5%. Because if the patient feels something only, they'll come to the treatment. Snoring, only simple sound, they may not come. But if they feel something only, they'll come, and most of the patients, they are into high risk category only. And number of sleep studies done was total 38, and sometimes some patients they did outside, but that's not included in this number. And total number of DICE, drug induced sleep studies done was 14, and in all these patients, 16 patients we did septoplasty. Some patients they need multi-staged procedures. So after septoplasty, they may need palatoplasty. Some patients we do first palatoplasty and tonsillectomy. Tonsils are very huge. So these multi-stage procedures with the septoplasty and palatoplasty were total 8 number of patients, and only palatoplasty is 2. But in these one patient already septoplasty done long back. Another patient septoplasty is scheduled later stage. This emphasizes the importance of multi-stage surgery. And here are some case reports. And first case one is a 50-year male patient. Mohan Reddy sir already told, this patient came very much bloated with so much of nasal congestion symptoms. Initially he was treated with the septoplasty and FES, and after the FES sleep study is done. With AHI, this comes is a moderate case. AHI is 14 only, and with BMI is 28.4, means this patient is like moderately obese, moderately AHI, but this patient his main problem is uncontrolled diabetes and excessive daytime sleepiness. He can't do continuously a single work, he can't drive. If you want to long drive, he used to drive for an hour, 1 hour, we used to sleep for an hour. Like that, his daytime sleepiness is a chief complaint. But after palatoplasty and ovular reconstruction surgery, his sleep study is reported, and surprisingly it came to 0.8. Even normal is less than 5 is the normal thing. So AHI came to 0.8, and he is comfortably living without any daytime sleepiness, and sugars are better controlled now. And now we enroll the patient into lifestyle modification program for the better control of the diabetes, and to maintain success of these kind of surgeries, preventing weight gain is very important. Even if we gain some weight, even 5 kgs, even with minimal amount of the weight gain also impair the results of these kind of surgeries. For that thing, we enroll the patient into the program. And this is a second case. This patient is a young patient. He is only 35 years old. His main complaints are snoring daily and morning headaches. He is looking very sick actually. Though he is 35 years old, and his examination showing he has a DNS, long palate and short neck, BMI is 33. Because of his short stature, he is not, he is only 85 kgs, but his BMI is 33. And DICE was done before no surgery. Sorry, I forgot to tell, this is his AHI is 130. 130 AHI is very, very, very high. So DICE was done before septoplasty surgery. His findings are very interesting. His arytenoids and AE folds, they are going into his glottis with every inspiration. So that is the reason could be explaining it's very high AHI. These kind of things we can see only in the DICE. So that DICE is very important in upper airway obstruction, in understanding what happening during the sleep. No one can see. We can only make the person sleep and see. His arytenoids are normal, glottis is normal during the sleep, during daytime. But they are blocking, they are making him to choke. That's why even in this young age also he developed so much of symptoms with high AHI number. And CPAP, I just want to mention an interesting point into the CPAP. Usually splits the upper airway at the level of the palate, tongue blaze, and it opens the airway properly. But if a patient has a floppy epiglottis or these kind of flappy AE folds, this positive pressure, it worsens the obstruction. That means it pushes the things, epiglottis, with the positive pressure jet from upside, it further pushes the things inside. Means, sir, is it okay? Mic, it's not working, sir. Now it's working. Okay, sir. So it further pushes them down. So these patients definitely, they don't get benefit from the CPAP. They tell after using the CPAP, my symptoms are worsening. If someone is prescribed the CPAP, please, if that patient is telling my symptoms are worsening after the CPAP use, we should consider the obstructions, because with the nasal obstructions, especially glottis level of obstructions, they feel those obstructions are worse with CPAP. So, and even in the CPAP data we can see that that snoring and airflow limitations, they won't improve with the CPAP, and this flow limitation pattern shows flattened inspiratory flow curve. That inspiratory flow, it get flattened with continuous pressure coming from upside. And that patient also complains choking, discomfort with CPAP use, and he feel like air hunger. He literally feels choking. So DICE, we can confirm while using, we can put the CPAP and we can do the DICE, and we can confirm those findings also in those patients. I mean CPAP non-compliance also, this is also very important. Yes. CPAP in these patients, it's making my problem worse. I can't breathe out with it. This is the thing patient told. And this patient, he is using hypothyroidism treatment for 1.5 years, and apparently is all surgical profile and preliminary investigations are normal. But when we was done detailed investigation to take into lifestyle disease reversal program, he has high fasting insulin, and he has antithyroid antibodies, and high levels of homocysteine. It's a kind of, he is into stage of pre-diabetes, he is into pre-hypertension, pre-cardiac cardiac disease. Means is a picture of metabolic syndrome, not evident, but we can pick up all those things in lifestyle program. And once this patient into these things, we can reverse. Means OSA already made a young person to develop into metabolic syndrome, which was not obvious, but we can reverse all these things also with the lifestyle disease program. That's why we have enrolled the patient into lifestyle program. This is a picture of all the deranged investigations, which were not usually picked up by our routine surgical profile or blood test, all those things. And this is a case 3. She's a 53-year-old female patient. She's very morbidly obese, and her main complaint is snoring for so many years with excessive daytime sleepiness. His AHI is 76, and her daytime sleepiness is so bad. While eating also, she used to eat and drop the plate and sleep. She's the sleepiness is very bad, and she has huge tonsils and long palate. That's why we have taken her for tonsillectomy and palatoplasty first place. 4 months later, we taken her for septoplasty and tornoplasty. After the surgery, her AHI is 36. So this residual part is mainly due to her obesity, thick neck. She has a very bulky double chin, thick neck fat and bulky parotids. This all things can be reduced with this lifestyle disease program. And why to take these kind of morbid patients means even 50% of reduction of AHI is considered as a successful surgery. And relieving the obstructions will help the patient for better weight loss and better CPAP use. And this is a case for 46 years old male patient. His main complaint, he used to wake up from the sleep so many times with air hunger and choking feeling. And he is very, means he is not typical OSA patient. He is very thin built, non-obese. He is not even obese. He was evaluated so many times for cardiac evaluation because that patient is typically telling my heart rate is going up, I am feeling so scary, I am not able to sleep properly, I am feeling choking. And his sleep study is also, AHI is 10.8 only, that is even moderate, not severe. So this AHI is not corresponding with the symptoms of the patient. But when DICE was done, he has a primary collapse of epiglottis. So that is making him choking. This means his epiglottis is closing like a door while he is sleeping. Okay. So this case signifies the importance of DICE in airway management with lesser AHI and more symptoms, especially in non-obese individuals. Whether it is a UARS or OSA, this is not, patient have different symptoms. OSA people, they have more apneas and they sleep more. During night time, during daytime, they sleep more, they become more obese. That's a different picture. In upper airway resistance syndrome, patients usually thin, they can't sleep, they have insomnia, they can't sleep, even they want to sleep, they can't sleep more than 3 to 4 hours. They usually wake up. This kind of patient comes with upper airway resistance syndrome, but means they don't have higher AHI. Sometimes it can be diagnosed with RERA. RERAs means they don't have apneas. Apneas mechanism of action on the brain is different, and RERA's action of mechanism on the brain is different. Typically they non-obese, they are more complaining of insomnia and fatigue. Not only this, there are so many cases. I pain, sir. I pain. So, yes, sir. This is finished, sir. Yes, sir. Presentation can be different. It can be a young 16-year-old boy presented with resistant hypertension, and a young student who can't sleep because of daytime sleepiness, bank employee, manager level, he can't even sign a check because he is sleeping all the time, and some patients, they can't sleep because they have choking sensation. So for all patients, taking proper history and airway assessment, doing DICE, sleep study, and treating all the comorbidities, it's all very important for whole treatment of the patient obstructions. Yes, thank you.
Yeah. So as you heard, in our experience now with the pilot project, we have seen the patients with a very big AHI or morbid obesity and without obesity. So all these things, what I was telling you about that importance of team approaches, our job as ENT specialists is we identify the site of obstruction, cause of obstruction. Cause can be obesity related, fat and narrowing, and tongue and all those structures in the throat, tonsils, palate, uvula, all those things, and becoming flabbo, they have to be attended by surgery. Lifestyle, it takes longer time. So mild cases we encourage lifestyle. If they are compliant, very motivated, okay, they can go for that, not necessary. Allergies, if they are there, if there are turbinate. So we will assess with our form and DICE and clinical examination. We are concerned with upper airway. We are upper airway specialists. So the cause, primary cause, upper airway obstruction elements we have to rule out. Then investigations, when it is moderate cases, if the patient is highly motivated, first to go to lifestyle medicine. But lifestyle medicine, we all know it is not, but that is the gold standard. We have to go back to our lifestyle of old days. Definitely. When we didn't eat all those things, pollution, and nobody had this obesity and all naturally. So, but that is reversing our lifestyle is definitely such. But moderate cases, before that, we have to intervene airway, restore the airway, patency. That is our job. We do that. But I stress my patients, you have to go like this, because I was not happy with the result. It was only half result what we are giving, and he will go back again to the problem. So to sustain, that's important. That's how we manage ENT, lifestyle, and now the Supraja, the diet part, inflammation aspects, what he has told, how the diet will.
You can hear me. Yeah, right. So the food that you're eating today is whole food plant-based. Dr. Murthy has already explained the concept of how fiber is very important, fruits and vegetables are very important, and how dairy is inflammatory, and so anything to do with the dairy, and how oil can increase, for the inflammation in the body. So all the food that you're tasting right now is dairy-free, oil-free, refined-free. Again, one of the toxins that he was talking about, refined foods. So the food that you're eating has, the starters. So fiber is very critical, and eating more natural food, eating more foods that are the most natural form is critical, right? So you have a sprout salad. The sprout salad has vegetables in it. Apart from the moon sprouts, okay, we all know sprouts are very beneficial for our body, right? But when you add veggies to it, and there is a dressing, can you taste that it doesn't taste like your regular sprout salad, it tastes a little different. So we've done a Thai dressing, it's a peanut satay dressing. So we've given it twist, like just so you can get the flavor of different brand rather than just standard Indian cuisine. So one salad we have. The other salad that you ate, what was it? I'm sure all of you love your chaat. Papdi chaat. Okay, so the papdi chaat, the papdis are baked. They're not fried papdis. And the chutneys and everything else is all, like made fresh. There's nothing that is bought. Okay. And then, like he spoke about the importance of millets, so we try to do a foxtail millet pulao. Okay, because of the transport and all of that, it's time to become a little dry, but that's why we've added the raita to it also. But what we're trying to say is that you don't always have to eat rice, and you don't have to definitely eat white rice. There are alternatives which, so we wanted to give you a sample of how millet pulao can taste. It's very easy to make it similar to how you make rice pulao. Add more vegetables. Right? So this is foxtail millet that we use to make the pulao. And complement it, obviously we don't want dairy, right? So what do you think the curd that the raita is made of? Not peanut curd. So it's soy curd. Okay, so soy curd is being used. There is also peanut curd, which we also have kept as a backup. But we use soy curd, and now soy, to understand, is very, very powerful in terms of its nutrient profile, high in protein, and then it's got phytoestrogens which are very beneficial for the body. And of course, it comes with lots of fiber. So we try to use soy curd to give you the flavor of not missing out on your regular dairy curd raita, right? And we also there is something called, does it taste a little like makhan wala, paneer makhan wala? Yeah. The gravy that you have, does it taste like paneer makhan wala? So we tried to actually replace the paneer with tofu again. Okay, so that's tofu makhan wala kind of a thing that we've done, which is tofu in a cashew-based gravy kind of a thing with all the masalas and all of that. So what we try to create here is give you a diverse cuisine, including both South Indian, North Indian, a little bit of international flavor, and we have dessert also. Okay, so you can go for your refill and then go for dessert. And then you can tell me, it's a quiz. You can tell me what the dessert is made of. Okay? So the whole approach that we're trying to follow is not change your food habits. Lifestyle modification does not mean you have to change everything, that you have to do a diet. So all that you need to do is whatever you're eating currently, how do you make it healthier? How do you make it oil-free, dairy-free, refined-free? How can you add more vegetables to your plate? How can you add more color to your plate? How can you add more fruits? So on a daily basis, we believe, and there is nothing more research to show that you can get leafy greens, you can get fruits, you can get vegetables, you can get sprouts, and you can get whole grains like millet, unpolished millet and brown rice and those kind of things. Then your health will be vital. There is no doubt about it. The body will respond, the body will cut down on inflammation, and you will feel very well. I mean, there are people we've seen in our practice cases within 10 days people start feeling more energetic. And Radhika ma'am herself has experienced it and she shared her testimonies, right? So it's a matter of just trying it. Try doing this for even a month and you will see it. They say it takes 21 days to change a habit. So just do it for 21 days.
So I wrote a.
I thank this program. Usually, she came just from the airport. She flew from Bombay and came here to the airport. And the last few days, she was working on this recipe with the nice ingredients and all kind of things. So many thanks for that.
And I still have to.
I was planning the thinking how to make people, my patients at least, all these things I was doing it. And one, all of them including ourselves in the pilot project. So all of them, I think here, many of us, most of them here, look like normal. In our mind, what we need is lifestyle. Mother, nearby more, I think, what more we have to do. I think definitely not surgical cases. So if you don't follow, then something to do. I will tell you, Radhika, there are convinced that you
one question, sir.
Yes.
The outfit that I commented was psychology.
Yes, sir. So that's a very good question. So you can ask me. So can you all hear me? So the question is, I said meat causes when it digests 3 things and they are not good. But what about eggs? So if you remember in the past, your eggs used to come from your chicken that were raised in your yard. Yeah, please go for the refills. Your dinner is not just that. Please, there is a lot of food there. Okay? So the chicken used to be like raised, they ate from the earth, and that's how they were. They used to be minimal. But now everything is hormone raised, and then you got more eggs. In America, first allergic substance was dairy. Now it has become eggs. Because everything's hormone. But then scientifically, I'll tell you what happens when you eat eggs. It has got very good things, like phosphatidylcholine. The choline is very important for nerves, very good for the brain. But then the egg yolk has 300 milligrams of cholesterol. The white is great protein. But what happens when it digests is the phosphatidylcholine gets converted to TMA, trimethylamine oxide. That TMA, as I told, we are all eating so many calories, that gets converted to cholesterol. That TMA takes cholesterol and puts it in the blood. So, why do I need that data? If you say, what's the safest? They have done research. If you're normal, that's no health problems, no nothing, your BMI is good, 1 to 2 eggs. But if you have diabetes, you have high blood pressure, you have cholesterol, you have heart disease, avoid. Stop. See, in lifestyle, true. Then what do you eat? You know, people question, hey, when I give up all this meat, where is my protein? I'll tell you, a female needs 46 grams of protein per day. A man needs 56 grams. Masoor dal, 1 cup,
gives you 15 grams. Please do the math. I need 4 cups, she needs 3 cups. If you remember our diet used to start with mudapappu first, that's 1 cup. Then after that you had curry. Then you had poppu, which is another cup. Then you had chadu, that's another cup. So that's how, but we changed all that. The only one thing that you all have to be careful when you go to plant-based, take B12 vitamins. You must take a B12 vitamin when you go whole food plant-based.
Second about the fasting.
Yeah, go fantastic.
I read about this. Look at what, how many hours the autophagy starts? It is 16 or 18 or 24.
So it's a good question. He asked, intermittent fasting is good, but what is the duration? When does autophagy start? When do all these things happen? For me, I really don't care. It's what's important is what are you doing after the intermittent fasting? If you're going for 4 a.m. biryani after intermittent fasting, it's waste of your time, right? So the point is, after when we eat and we sleep, right, all the calories are converted to glucose and stored in the liver for glycogen. 6 to 8 hours, it's all gone. Okay? So the good thing is to do at least minimum of 8 hours, and so 12 hours is good, 16 hours is good. But during the window, you should eat whole food plant-based. But you can't eat fried products, burgers, French fries. That's a problem. So you don't have to worry. So just do anything above 8, you'll be fine.
Comment about prolonged fasting, 24 hours.
Yeah, you can do 24, 36 hours. The more you do, the better for you. Because after a while, your fat starts getting mobilized. It's called ketonic state. You can actually check your urine. Even in Amazon, you'll get that ketone test strips. If you can be on ketonic state, that's the best way because your brain needs ketones. So you'll actually be very active. And so our rishis and munis, they did more fasting when they were doing meditation. And they did all these yoga techniques, so they didn't need a lot of food. If you go to Himalayas, what do you get food except ice there, right? So they literally had power by doing all these things, by breathing air, then they could generate their energy. And that's true because the mitochondria actually gets declogged. When you do all these techniques, like fasting, then you feel more energy, you have ATP. Because you have to understand, when you give more fat, it all gets deposited in various cells. And your mitochondria, it's like what happens if there is a scooter, you go and put your foot near the exhaust pipe. Stops, right, the engine? Same thing. So when you fast, it's like you're opening up everything. It's a good thing.
Taking out GA index, they have to consider vinegar subjects.
It's very good, apple cider vinegar, but you can't drink it like that, you have to dilute it. So if you all want one very good app that's free and it's all science-based, can you pull up your iPhone or Samsung? Please download this app, it's free, it's not for profit. You will get all these questions answered with science. It's called Daily Dozen by Michael Greger. Daily Dozen. Please download it. And Dr. Greger gives you.
When Sadhana also has got low GA.
Right. It's good, sir. But if you look, when they did Sadhana in the past, they didn't know how to polish rice. They used to beat up, and that's how it was. But from there, we started polishing. Why refined is bad? Because it takes chemicals to refine things. And all those chemicals are in that product. And when you eat, the body doesn't understand. It just inflames. Then fermentation exists. Right. Fermentation. Overnight. And I wrote, I'm coming up with a book where I'm bringing Ashtanga Yoga back into modern medicine and creating habits. But we came out with a book called Meal to Heal, International Disease Reversal Book. You all can get a copy if you want, because we have been patiently waiting. So if you don't want also, that's fine. You have. So I can go and give you see what you want. It's okay. I would rather see each other. So please. Yeah, I was only in the screenplay and direction. The authors are different. Story was two women there. I'm coming up with Indian one. Should have come, but they're also see that it was. Hey, he has it.
Research was done on these two numbers, the total cholesterol less than 140 LDL. But I want you to understand, in US, we actually do what is called fractionation of LDL, fractionation of HDL, because not all LDL is bad. There are 5 fractions, the lighter one and the denser one, same thing with HDL. So you check all that and you change the diet, because each one can be affected. And lipoprotein A and APO A and B are also important. Homocysteine are important. So coming back to so A1C, every one A1C that goes up, your risk of death goes up by 18%. So that's why it's important you keep the A1C below 5.4 all the time. Sir, 5.4 andi. So then the gut, it changes dynamically, but the easiest way to change is fix the 6 pillars. They have done reversing of dementia. It's called Finnish people, 2,800 people. They have checked. They ate whole food plant-based diet. They exercised aerobic exercise 5 times a week. Resistance training 3 times a week. They slept by 10 p.m. No smoking, no alcohol. Everybody had stress reduction techniques by meditation. They literally shown that cognition declines. Rate is very much reduced. And it's called, now they have done what is called finger trial. So the gut leaks, and that's causes the proteins to go up, causes the amyloid plaque and dementia and memory problems. Gut leaks, then the inflammatory markers get in and all the chronic diseases come. So gut is our Ayurvedic people have figured it out, and they created all this sattvic diet, fasting, cleansing. You know, they used to give castor oil to kind of flush out your thing. I'm sure my mother gave me, I used to hate that day when I had to drink castor oil. So we had all these simple techniques to take care of the gut. And we used to play in the soil. The people, there's actually a study, if you have a dog in the house, your gut microbiome is much better than if you don't have a dog. You know why? Because the dog plays outside and you do this and then you do all that, so you have better gut microbiome. So I'm just telling you, this, they have done this study also. The point I'm trying to make is, we used to be in the nature, Indians, they never sat. But nowadays, you sit inside the house all your life. You never go out. So things have changed. So these are all the reasons. And then plastic bottles, scents, all these chemicals, detergents, all the toxins. So that's why I came up with that 8-driver approach to kind of take care of chronic diseases rather than just one approach. And then habit change. You know, you all have phones. You can go to AI and create all the knowledge you want through the AI. But how do you actually change habits is you need a coach. You need to slowly change. If you're motivated, fine, good for you. But in my practice, you know, they pay me membership fees. I have 3 levels. People, I don't take everybody who comes to my door. They have to pay $1,000 per year, $1,500 or $2,500. 3 levels. Only 50% success. They pay me, but they don't want to do what I tell them.
That's what I told. Now even Tendulkar requires
Needs a coach. So that's why I said patient is the boss, doctor is the coach. So doctor, you see here, doctor means what? DR, disease reversal, not disease management.
Why is this little, take it easy about the cholesterol level?
No.
Has come in the US media.
No, the reason is, they'll say all these things, but because they are funded differently, they're all bought out. A lot of food industry is very powerful there. They fund all the universities, they fund everything. So the research comes to their advantage. You know, when things started changing is when the American Heart Association president fell off and he had a heart attack right when he was speaking. That's when, so it takes people like them to change. 1 sec. Thank you.